Good day, everyone. Because of the current habagat that we are experiencing, I opted actually to have this screencast of our lesson, our last topic for the midterm, and this would be the Mycobacterium or the acid-fast bacilli. This is a very long topic, and the topical outline would include the general characteristics of mycobacteria. What are the safety precautions that you have to observe as a medical technologist? And because of that, you'll be allowed to properly collect specimen and handle it in the laboratory. And of course, as a medical technologist, it is also our responsibility to know the procedures for the isolation and identification of isolates. And lastly, of course, we want to enumerate some of the clinically significant mycobacterium and infections that they produce. So what would be the general characteristics of mycobacteria? Mycobacteria are non-motile, they are slender, slightly curved, rod-shaped, non-spore forming. One of the most important characteristics of mycobacteria is the presence of high lipid content known as the mycolic acid. And because of the presence of mycolic acid, it will be very difficult for us to stain mycobacterium using a gram stain. So, instead of using a gram stain, we will be using the acid-fast stain. Now, aside from the fact that it also requires complex media for us to cultivate them. Now, going back to the acid-fast stain, probably you are wondering, why do we call this microorganism acid-fast bacilli? In order for you to understand the meaning acid-fast, then you have to be familiar with the acid-fast staining. There are two main methods for the acid-fast stain. These are the Ziehl-Nielsen method and the other one is the Quignon's method. The Ziehl-Nielsen method is also known as the steam method because primarily it allows steaming or it uses steaming. On the other hand, Quignon's method is also known as the cold method because obviously there's no steaming whenever you are doing the Quignon's method. Now, both of these would be using carbolfuchsin. What is a carbolfuchsin? Well, carbolfuchsin is a stain that would be able to penetrate the very thick lipid content or the mycolic acid in the cell wall of the mycobacterium. And of course, both of these methods would also be using acid alcohol as the colorizer. Acid alcohol, in contrary to your gram stain, which utilizes the mixture of acetone and alcohol, acid alcohol is actually made up of alcohol and hydrochloric acid. So, it is a mixture of alcohol and hydrochloric acid. Okay. They also differ in terms of the counterstain. For the Ziehl-Nielsen method, it utilizes the methylene blue and as a result, non-acid facet stain blue. On the other hand, the Quignon's method would be using malachite green. And as a result, non-acid fast organisms would be stained green. Now, in terms of methodology, Ziehl-Nielsen method would utilize steaming. Steaming is a very important process during staining of the acid fast because in the presence of heat, it would facilitate the penetration of carbolfuchsin into the cell wall of the mycobacterium. Now, in Quignon's method, it is known as the cold method because there's no steaming. Instead of steaming, we increase the concentration of carbolfuchsin, or we also prolong the contact of carbolfuchsin, prolong relatively compared to the Quignon's or to the Ziehl-Nielsen method, or some other method would employ the addition of a wetting agent known as the tergitol. So tergitol is an example of the wetting agent. Okay, now both of these, Ziehl-Nielsen and Quignon's method, would stain red. Now, let's go back to the question. Why do we call it acid fast? Acid fast because of the fact that they resist, okay, they have the ability to resist to resist decolorization by an acid alcohol. Now, this is a unique characteristic as compared to other microorganisms. Okay. So, let's now continue. Now, Mycobacterium is also a strictly aerobic microorganisms, which means that they would require oxygen in order for them to grow. This is unique as compared to other bacteria because of the fact that some bacteria would be facultative or aerotolerant, but microorganisms such as Mycobacterium is an example of strictly aerobic. This could explain the reason why Mycobacterium tuberculosis would probably occupy the alveoli of our lung, because the alveoli of our lung would be very rich in oxygen. They are said to be slow grower. Majority of these pathogenic organisms would be slow grower. Those associated with diseases would take about 2 to 6 weeks. So that's the reason why if you're going to incubate Mycobacterium, it would require you to have a very thick agar as compared to your ordinary microorganisms, in which after 24 hours you'll be able to see visible growth in the colonies. But here for Mycobacterium, it would take about 2 to 6 weeks before you'll be able to see visible colonies. And moreover, Mycobacterium tuberculosis is enhanced with the addition of about 5 to 10% carbon dioxide. On the other hand, another significantly important species of Mycobacterium is Mycobacterium leprae. This particular organism fails to grow in vitro, but interestingly, this organism could be cultivated using the foot pad of an armadillo. So, these are the different clinically significant species of Mycobacterium. So, if you want to have a clearer picture of this one, then you may go to box 26-1 of Mahon, our official textbook. Mycobacterium tuberculosis complex. This complex is made up of pathogenic Mycobacterium. Most of these are pathogens that could be seen in United States, but of course it could also be seen here in the Philippines. So these include the Mycobacterium tuberculosis, the Mycobacterium avium intracellulare complex, and the Mycobacterium bovis. Interestingly, Mycobacterium bovis is the source of the BCG, the Bacillus calmette-guerin, the attenuated, okay, so the attenuated form of Mycobacterium bovis is the source of the BCG. This one is actually a vaccine being given to neonates. Okay. There are some species that are not usually seen in the United States but could be common here in the Philippines. An example would be Mycobacterium leprae, also known as the Hansen's bacillus. Okay. Mycobacterium leprae obviously can cause leprosy. Then, in Africa, the most common species that would cause tuberculosis is known as the Mycobacterium africanum and Mycobacterium microti. However, Mycobacterium microti is not associated with human diseases. So, let us now discuss Mycobacterium tuberculosis. It was first discovered by Robert Koch. So, that's the reason why it is known as the Koch bacillus. Before, there was no cure for Mycobacterium tuberculosis. That is the reason why it is called as the captain of all men's death. In fact, you know this guy here? This is Manuel L. Quezon. This guy actually died from Mycobacterium tuberculosis. Okay, from tuberculosis infection. And that is the reason why the primary institute here in the Philippines, QI or Quezon Institute, is named after him. Okay, so of course it is known as the human tubercle bacilli because of the fact that it could cause tubercle of the lungs. So it is an acid-fast bacilli. As you can see in the illustration, they are long, slender, straight, or curved rods. And they could be somehow pleomorphic, which means that They could exhibit a variety of shape. They tend to grow in cord, okay, in strands, as you can see here. There's a strand. Okay, so this strand is known as the cord factor, and very important to take note, cord factor is considered as a virulence factor for Mycobacterium tuberculosis. It is also known as the serpentine cord formation. So there's supposed to be letter N here. Serpentine cord formation. So Mycobacterium tuberculosis does not produce a toxin. Let me go back. Okay. So Mycobacterium tuberculosis does not produce toxins. Okay. However, the pathogenicity is due to the presence of cord factor. So only virulent strains of Mycobacterium tuberculosis would have this cord factor, which is responsible for this one. This is what you call the serpentine cord formation. Okay, so those that are not virulent do not exhibit this particular characteristic. Okay. So this compound is highly toxic to animals, although the role it plays in human disease is not yet known. Another important characteristic of the organisms. Do you know that once our alveolar macrophage, this is the macrophage found in our lungs, phagocytize Mycobacterium tuberculosis, Mycobacterium tuberculosis is so virulent that they have the ability to survive inside the phagocytic cells. So, what will happen if you have tuberculosis? Then, you'll have the so-called first, the primary tuberculosis, wherein the signs and symptoms would include, of course, fever, and then this fever is usually seen in the afternoon. So, fatigue, you're weak, there would be night sweat, and then progressive weight loss, dyspnea, coughing, chest pain, and of course, one of the cinematic, should I say cinematic? Because most of the time, whenever people in the television or in the movies would portray someone with tuberculosis, they would always exhibit the sign hemoptysis, which means that there is coughing out of blood. Now, if you're going to have a biopsy or autopsy of the lungs, you'll be able to see two types of lesion. We will try to differentiate them later. The exudative lesion and the granulomatous lesion. Okay, most of the people with tuberculosis will be given antibiotics that would last for about 6 months. Now, you might be wondering, why 6 months? How come, for example, if you have E. coli or S. aureus infection, the antibiotic regimen would only be about for 1 week? Well, it is primarily because of the fact that the organisms are slow grower. So, 6 months. Originally, 2 years if you're going to take this antibiotic individually. So, later on, we will tackle that. However, let's say, for example, you did not finish the antibiotic regimen. Then, you might experience this so-called secondary tuberculosis, wherein there is a reactivation or reinfection. Now, if you are not able to contain the infection in the lungs, then it would become disseminated, or we call it the extrapulmonary tuberculosis. So, once you get the organisms by means of a droplets, okay, so the organisms will of course go to your lungs. So what will happen in the lungs is that the cavity open into bronchi. Okay, so this is the organisms. Okay, allowing the spread of Mycobacterium tuberculosis, and usually get it through coughing. Okay, now some of the macrophages, let's say for example, this would be the macrophages. As part of the defense of our body, they will engulf the organisms. However, because of their virulence, these organisms will multiply inside the macrophages until there will come a time that the macrophages, the organisms will be liberated from the macrophages. Okay, so it says here that 90 to 95% of infected individuals would have the hematogenous spread. Okay, and it is detected by PCR in situ, which means that you usually get the specimen from the site of the infection. Okay, 5 to 10% of infected individuals will result into progression to cavitary tuberculosis. Okay. Now, reactivation happens when, of course, you did not finish the regimen, or there would be lifestyle costs, such as, of course, smoking, or if you are an immunocompromised individual, such as in cases of HIV infection. So, in summary, as you can see, primary tuberculosis is transmitted by airborne. So they infect the lower respiratory tract, particularly in the alveoli. Even though they are phagocytized, they continue to multiply. And 4 to 6 weeks later, T cells, an important cell for cell-mediated immunity, will synthesize and allow destruction of intracellular bacteria. Eventually, there will be regression and healing of the primary lesion. This is the hope or a good prognostic index. However, reactivation could possibly happen, particularly if there is no chemotherapeutic regimen. PPD is the tuberculin skin testing. So PPD is known as the purified protein derivative. So we will discuss more of this during the diagnostics. So again, this illustration will show us the primary lesion of Mycobacterium tuberculosis. Now, an important illustration here is this one. This happens during the post-primary disease wherein the organisms were liberated from the cavitating lesion, and this could be the start of the extrapulmonary tuberculosis. Reactivation can occur for those who are old age, immunocompromised, or not well-nourished individuals. So this is a chest x-ray of a person with primary tuberculosis. Of course, we will not deal with this. In case that you want to be a radiologist in the future, then you'll be dealing with the interpretation and analysis of this x-ray film. Now, this one is an example of the exudative lesion, one of the lesions that you could probably see in the lungs. So take note of this particular cheesy necrotic tissues. And then this one is a granulomatous lesion. So if you're another cheesy necrosis that you could possibly see here. Now, if you're going to check under the microscope, so you'll be able to see the tubercle. The tubercle is actually being surrounded by these macrophages so that the infection will be localized. However, Mycobacterium would have this ability to multiply, and eventually they would escape out of the tubercle, and this would be the start of the extrapulmonary tuberculosis. So, exudative lesion is characterized by acute inflammatory reaction with edema fluid, neutrophils, alveolar macrophages, and they try to surround the AFB or the acid-fast bacilli. Now, the granulomatous lesion is characterized by the presence of tubercle. So, a central area of giant cells containing TB surrounded by a zone of epithelial cells and fibrous connective tissue. So, the granulomatous lesion is also characterized by a caseous lesion, as what I've shown you before a while ago. So, it has this cheese-like consistency, as shown in the gross examination. So, extrapulmonary tuberculosis is also known as the miliary tuberculosis. It is the spread of bacteria from lungs to the bloodstream, which means that the infection goes out of the lungs. So it is not only the lungs that would be affected in miliary tuberculosis. So organs such as spleen, liver, bone marrow, kidney, adrenal glands, and eyes could also be affected. Now, it occurs most often in children and also in HIV positive patients, probably because of the fact that these people are immunocompromised. So, genitourinary tuberculosis would exhibit UTI-like symptoms, so characterized by pyuria. So the term pyuria is the presence of pus in the urine. Skeletal tuberculosis is otherwise known as the Pott's disease, or sometimes it is known as the TB of the spine if the spinal cord is affected. So it's characterized by back pain, involvement of the hip and knee. So, Pott's disease is would usually result into paralysis. So, as what I mentioned to you a while ago, it is known as the spine tuberculosis. Then, lupus vulgaris would affect the skin. Scrotula will affect the lymph node. TB synovitis, this could be another example of skeletal tuberculosis, which affects hips, bone, wrist, elbow, or where the joints are. Then, renal tuberculosis affects, of course, the kidneys, characterized by dysuria, hematuria, or the presence of RBC in the urine, and of course, fever. Then, genital tuberculosis may affect your reproductive function. And then, the TB meningitis will result into mental deterioration, retardation, blindness, and deafness. So, this is an illustration showing us the Pott's disease or the TB of the spine. So, take note that in the illustration, there is a degradation, okay, the vertebra. Then, this one is lupus vulgaris or the TB of the skin. Scrotula is the tuberculosis of the lymph node. TB meningitis could also somehow result into paralysis. Renal tuberculosis primarily affecting the kidneys. Okay, so other causative agents of tuberculosis include the Mycobacterium bovis, also known as the bovine tubercle bacillus. The reason why we call it bovine, because cows or the cattle are the common reservoir. Okay, in humans, the gastrointestinal tract is commonly affected because of the fact that sometimes humans would drink contaminated milk or milk that has not yet been pasteurized. Okay, in Africa, as what I told you a while ago, the most common etiologic agent of tuberculosis is Mycobacterium africanum. Okay, now, the treatment for tuberculosis is known as the quadruple therapy. Quadruple therapy is made up of isoniazid, rifampicin, pyrazinamide, and ethambutol. So these four would be the most common component. Okay? Now, streptomycin could also be used if any of these antibiotics would become resistant. Okay? So, here in the Philippines, we have a program known as the DOTS, otherwise known as the Direct Observed Treatment Short Course. Its main objective is to monitor patients' compliance to drug regimen. Because before, usually what will happen is that they will just give the patient will just go to the health center, and then the patient will bring home the drugs. Then some of these patients will tend to sell the drug, or sometimes they would forget to drink the antibiotics. So what will happen is that Mycobacterium tuberculosis had eventually developed resistance. And because of that resistance, then of course, it would be harder for us to treat the infection. So because of this scenario, the government had actually established the so-called DOTS. Here in DOTS, each rural health unit or barangay is supposed to have this DOTS center wherein the patient would have to go daily to the center, and the person involved in the center, usually a community health nurse, would see to it that the patient would be religiously drinking these antibiotics. Okay, so if you're going to take this antibiotic individually, let's say rifampicin only, it will take you 2 years to complete the regimen. And because of the combination of this one is an example of combination therapy. So it is shortened to 6 months. But 6 months. But I think here in text, it says differently. Okay, so what would be the action of these antibiotics? Rifampicins would inhibit DNA-dependent polymerase. And if you are going to inhibit this one, then the organisms will not be able anymore to produce the nucleic acid necessary for them to multiply. Pyrazinamide would minimize relapse and shorten the treatment. So you prevent reactivation. And then ethambutol will inhibit the incorporation of mycolic acid in the cell wall. So without mycolic acid, then it will not strengthen the cell wall of the mycobacterium. And then isoniazid would interfere with DNA synthesis. And because of this, there would be inhibition of mycolic acid. Okay, so yeah, it's a 9-month course of therapy. Okay, so if you're going to use isoniazid and rifampicin, but I think that the OTS had incorporated the 4 antibiotics, so that's why the treatment had become 6 months only. So other drugs, if resistant, would be kanamycin and ciprofloxacin. Okay, so treatment failure is usually due to non-compliance of the patient. So that's the reason why the DOTS was created, okay, in order to monitor the compliance of the patient. Drug-resistant mycobacteria would usually happen in non-compliance. And because of this, there would be MDR-TB and XDR-TB. Multi-drug-resistant tuberculosis, and then extensive drug-resistant tuberculosis, or the XDR-TB. MDR-TB happens when the second-generation aminoglycosides and fluoroquinolones had become resistant, or the bacteria had become resistant to these second-generation drugs. Okay? And if there are more drugs wherein the bacteria are resistant to, then we call it the XDR-TB. By the way, these two, I've actually incorporated the journal in our e-learning. You have to read that. And there would also be questions related to the journal. And you have to read the journal in the e-learning and answer the forum in our e-learning. Okay, prevention. Vaccination is usually being given to neonates. So the name of the vaccine is the BCG, the Bacillus calmette-guerin, the strains of live attenuated Mycobacterium bovis. Attenuated means that the organisms have already been rendered weakened. Okay, so it is hoped that you'll be able to produce antibodies against Mycobacterium tuberculosis. So this should also only be given to neonates. Okay, so as a medical technologist, particularly, let's say for example, you'll be assigned in QI or you'll be assigned in microbiology laboratory, wherein in the future you might handle specimen tainted with Mycobacterium tuberculosis or suspected to have Mycobacterium tuberculosis. It is very important that you observe this personnel safety. So we should be able to consider that each employee should have adequate safety equipment. Okay, you are well trained to perform safe laboratory procedures. You are well informed of the potential hazards associated with the procedures. And then you know what to do in cases of unexpected accident, and you have to monitor, okay, the personnel regularly, usually by means of skin tests, which we will discuss later. And then a mycobacterium laboratory should be separated with the rest of the laboratory because the organism is airborne. Okay, so there should be proper ventilation with negative air pressure, ideally with negative air pressure. Non-circulating ventilation, which means that there would be 6 to 12 room air changes per hour. So this must be a very expensive laboratory. Then of course, to prevent aerosols, when you say aerosols, these are infections that usually spread by means of airborne. Okay, so biologic safety cabinet, like the one we have in the laboratory. So the minimum requirement is the level 2 biosafety cabinet. So it should be properly installed and maintained, and of course you should be decontaminating the working surface here with disinfectant, and of course, ultraviolet light. And of course, you should use proper disinfectant. So, cover, surfacing towel, or absorbent pad soak in disinfectant. So, what would be the ideal disinfectant if you are dealing with Mycobacterium tuberculosis? So, it could be a mixture of phenol soap or sodium hypochlorite with a minimum of 1:50 dilution, then 3 to 8% formaldehyde or 5% phenol. Then ideally, the loop should be disposable. Okay, so there's a plastic loop that is said to be disposable, and you should have this PPE. Very important, because sometimes I'm observing some of you working in the laboratory without a lab gown, then you are missing out one of the important components of PPE, personal protective equipment, consisting of gloves, lab coats, gown, face mask, and in some cases, respirator. Take note of the fact that it is personal, which means that you are not supposed to borrow it. That is the reason why I'm actually kind of sad when I see you are lending your lab gowns to freshmen, or you are borrowing lab gown from other classes, because lab gowns are supposed to be personal property of an individual because it is a PPE. Okay, so what would be the acceptable specimen? So sputum that has been expectorated. So the sputum is what we call a first morning sputum, expectorated sputum. Very important that you should instruct the patient to have a deep cough, meaning to say they have to feel the diaphragm whenever they cough, something like that. Okay, and then instruct the patient to gargle with mouthwash so that bacteria in the oral cavity won't contaminate the specimen. Okay, sometimes normal saline nebulized induced sputum could be very ideal, especially if patient would find it difficult to expectorate their own sputum, or for neonates or for infants. Then transtracheal aspirate, bronchoalveolar lavage, laryngeal swab, or this one. This one is known as the FNAB, fine needle aspirate biopsy. So usually the pathologist or the doctor would aspirate tissue, okay, from the swollen lymph node of a patient. Okay, so patient with cervical tuberculosis or lymph nodes that are swollen. Body fluids could also be acceptable specimen, such as the pleural fluid, gastric aspirate, the CSF, stool, and urine. So most of the time, if a person is suspected to have the extra pulmonary tuberculosis, so this specimen would also be very ideal. Okay, body tissues such as the blood, bone, and skin. So again, this is also for the diagnosis of extrapulmonary tuberculosis. So in summary, you may refer to box 26-2 of your book to determine what are the different acceptable specimens for processing. Okay, digestion and decontamination. What would be the importance of digestion and contamination? Take note, let's say for example, the specimen is a sputum. You know for a fact that the sputum is mucoid sticky. And if you're going to examine the bacteria directly, there would be a minimal chance that you'll be able to see them. So there's a need for us to digest and decontaminate this specimen. So the purpose of digesting agent is to lyse the sputum. So that's the reason why most of the time we're using the mucolytic agent. And then the purpose of the contaminating agent is, of course, to remove unnecessary microorganisms. To remove unnecessary microorganisms or organisms that could probably contaminate the specimen. Okay, so the possible agents that we could use for this would be sodium hydroxide in the form of 2, 3, or 4%. Okay. So, this sodium hydroxide works two-way because they can act as the contaminating and digesting agent. And acetyl-L-cysteine serves as liquefying or mucolytic agent. And then, some would use benzalkonium chloride, which could also help digest and decontaminate. And oxalic acid, particularly if your CSF sample would have Pseudomonas aeruginosa. So, oxalic acid would be a good decontaminating agent. Okay. So, how do we concentrate the organism? So, after we apply this, then we have to centrifuge the specimen. Okay. Now, take note. Do not centrifuge the specimen in an open air. So, the centrifuge must be, the tube that contains the specimen must be well capped. Okay, then you cover the centrifuge and centrifuge the specimen inside a biosafety cabinet. So, there is a need for us to have a high-speed centrifugation to concentrate the specimen. Okay, so low speed would take longer and would expose bacteria to toxic chemical longer. So this is particularly important with large volume specimen. Forgive me if the voice becomes very blurred because the rain has started to pour again. When it rains, it pours. Anyway, so treatment of samples with mucolytic agents will help pellets the bacteria rather than the mucus. Okay, so how do we diagnose TB and what are the laboratory techniques that we could probably employ? So we could use the direct microscopic examination using the carbulfuchsin, the one I've told you a while ago in the introduction. And the other one would be by using a fluorochromes. So for the culture medium, we are using two types of culture media. So take note that we could use the solid medium. Now, the solid medium is further divided into agar-based, and the other one is egg-based. Then the liquid medium serves as the enrichment medium. Tuberculin testing is an example of skin test for tuberculosis. Okay? So later on we will discuss what are the different ways of doing the tuberculin testing. And then the biochemical testing. The biochemical testing is actually would allow us to phenotypically differentiate different species of Mycobacterium. Then of course, we could also perform the antimycobacterial susceptibility testing, wherein most of the time we're using the agar-based medium for this matter, and of course chest X-ray. Okay, now DOH has actually presented the proper way of doing the smear preparation. Okay, so the direct sputum smear, okay, method of the DOH says that you have to have a slide. Okay, for example, this is the slide, and then you should select about 3 by 2 centimeter in the area. Okay, and then after that, okay, you fish out the sputum. Okay, so you select the purulent particle of the sputum specimen. Okay, do not mix the sputum in the container because it may be a cause of loss probability of fishing of less AFB due to less number of AFB in the sputum. So, and then after that, you have to employ the repeated coil. So this is what you call the repeated coil. My stylus is big, so that's the reason it appears to be big, but it has to be fine. Okay, repeated coil until you are able to occupy the 2 by 3 as shown here. Okay, repeated coil. So after the repeated coil, then your specimen is now ready for staining. So you're not supposed to spread it this way or to spread it this way. We call it the one-way coil. Then you have to scan. You have to scan the smear before saying, oh, it's negative. So you can either employ the horizontal scanning, such as using this. I'm sorry. Let me go back. Okay. Can employ the so-called horizontal scanning. So horizontal scanning or the vertical scanning. Zigzag scanning is not the proper way of doing it. The reason why we do the proper scanning is so that there is an assurance that you won't miss out any field. Unlike if you're doing the zigzag scanning, so there's a chance that you might not examine one field in the smear. Okay, so how would we know if we have a false positive or false negative? Okay, so the checkpoint would be the size. Okay, it should not be too big or too small. So it should not be too big or too small. Then the evenness of the smear, it may result into false negative. Okay, the thickness, it should be not too thick or too thin. So that's the reason why the proper coiling is very important. Okay, so that you prevent smears that would be too thick or too thin. And then the cleanness of the slide. Dirt and artifacts may interfere, which could result also in false positive or in false negative. And then, sputum quality. See to it that the patient had indeed expectorated as sputum, not as saliva. Later on, we will be discussing how are we going to check if the patients have expectorated as sputum, not as saliva. And of course, staining. When you are doing the Ziehl-Neelsen, do not overheat. Or overheating will result into false positive and false negative. Insufficient heating will result into false negative because the carbofuscin would not be able to penetrate the cell wall containing the mycolic acid. Under decolorization is not too good. Of course, it will result either in false positive or false negative, and of course, over decolorization will result into false negative because the carbofuscin will be washed out in the smear. Okay. So, special staining requirement. We do not usually have gram stain because of the increased mycolic acid. So, increased mycolic acid would have irregular uptake of gram stain. But, of course, theoretically, Mycobacterium is gram positive. But we do not routinely employ gram staining for Mycobacterium. What we're doing is the Ziehl-Neelsen method and the Quignon's method, which I have already discussed a while ago in the introduction. So perhaps you are already familiar with this slide. But let me point out that there are other methods of acid-fast staining. So the Pappenheim's method differentiates Mycobacterium lacticola from Mycobacterium smegmatis, because Mycobacterium smegmatis is decolorized by the decolorizer consisting of prostholic acid and alcohol. Interestingly, guys, Mycobacterium smegmatis is found in the genitalia in smegma. Do you know what smegma in Tagalog? We call it kupal. So, it is usually seen in uncircumcised male. Kaya nga, a more social of saying na kupal ka would be smegma ka. Joke. Okay, natawa kayo doon, no? And then, another one would be the Baumgarten's method. Okay, it differentiates Mycobacterium leprae from Mycobacterium tuberculosis. So, Mycobacterium leprae is usually stained with dilute alcoholic fuchsin, coloring it red, while Mycobacterium does not readily take up the stain. So, there's another methods of acid-fast staining for you guys. Okay? So, don't be a smegma. Wake up. Okay, so this is an appearance of the Ziehl-Neelsen method. So, where is the Mycobacterium here? There. Okay? So, these bacteria would be what? Non-acid-fast organisms as they take up the methylene blue counterstain. So, Mycobacterium tuberculosis will take up the red acid-fast bacilli. Now, this structure here, WBC, why is it important? The presence of WBC could also be an indication that the specimen that you have collected is a sputum, not a saliva. If you see more epithelial cells rather than WBC or pus, then there's a chance that what you have collected is a saliva, not a sputum. Now, there is also a special stain for Mycobacterium. Okay. We call it the auramine, or the combination of the auramine-rhodamine fluorochrome stain, wherein the organisms would have a bright yellow orange bacilli that will glow in the dark. So, if you are employing this type of stain, then it is advisable that you have a fluorescent microscope. So, there is a need for you to use a fluorescent microscope because the organisms would be visualized under a UV lamp. Okay, so this is another example of the auramine-rhodamine stain. So usually they would be stained yellow or bright orange against a dark background. So this AR stain is actually more sensitive than acid-fast because it will be easier for us to see, more sensitive than Ziehl-Neelsen or the Kinyon's method because it will be easier for us to see these microorganisms as they usually glow in the dark against a dark background. But this specimen or this stain is more expensive as compared to the Ziehl-Neelsen or Kinyon's method, and it requires a special type of microscope. Okay, so this is the modified smear interpretation released by the CDC. But what I'm discussing is the DOH, National Standard Reporting Scale. So if you are assigned in RHU, Rural Health Unit, it's very important that you are familiar with this interpretation scheme. So you place 0 if you are not able to see acid-fast bacilli, but you have to visualize 300 fields. Plus N if you're able to see 1 to 9 AFV for every 100 microscopic field. Plus 1 if you're able to see about 10 up to 99 AFV for every 100, which means that here you are able to see at least 10 to 99 per 100 field. As compared here, you are able to see 1 to 9 only for every 100 fields. Okay? Plus 2, 1 to 10 AFB in just 50 visual fields. And plus 3, if you're able to see more than 10 AFB per OIF, per oil immersion field, in at least 20 visual fields. So, hindi nakakapagod kapag plus 3 yung specimen kasi 20 pa lang yung fields, then you are now able to see at least more than 10 AFB per oil immersion field. So which means that among these different interpretation scheme, this patient is heavily infected with Mycobacterium tuberculosis. Now, this is a test, a scoring technique for us to differentiate whether you are actually seeing a sputum sample or a saliva sample. So, what are we supposed to do? There's a scoring system. First, you assess the number of neutrophils in 10 field. If there are less than 10 neutrophil, then you score it as 0. If you're able to see 10 to 25 neutrophil, then you score the specimen plus 1. And then, if you are able to see more than 25 neutrophil in 10 fields, then you score the specimen plus 2. If the specimen is mucoid, then plus 1. Then you assess also the number of epithelial cells in 10 fields. If there are about 10 to 25 epithelial cells, then negative 1. If there are more than 25 epithelial cells, then negative 2. Then you sum up. If the final score is 0, or less than 0 or it's negative, then there is a lack of inflammatory response, which means that the specimen that you have collected is not a sputum, it is just a saliva, or there has been a salivary contamination. So you reject the specimen, you do not give interpretation, you ask the patient to recollect because you cannot properly diagnose the specimen if it's just a saliva sample. Instruct the patient how to properly collect the specimen. Okay, so I will now be cutting the slide because it might be too heavy, so there would be another recording for this one. Stand by for the culture media.